medicine that really focuses on diagnosis. And pathologists are the ones who are responsible for ensuring that all of the diagnostic tests that are required to make the right diagnosis for a patient, to follow their disease, to be able to determine their prognosis, and to decide the right treatments for each patient. And there are actually 4 major subdisciplines of pathology. One of them is biochemistry. So any one of you who has ever had a blood test or given urine to be analyzed, if you've ever had body fluids that have ever been examined, you will have had biochemical studies performed on those specimens to give answers that are usually generated in the form of numbers within or outside of a normal range, because biochemistry is very numerically focused, and we know from large populations what normal ranges are, and we know what's abnormal. Hematology is another field of pathology, and it's the study of blood. And basically, blood is made in the bone marrow and in the spleen, or at least the components of blood. The cells that are in the blood come from those places. And so anything that makes the blood abnormal is part of what hematology studies. And it includes blood transfusion. So looking at what kind of blood cells you have, what your compatibilities are. Anytime you've ever had a blood test to see if you have, for example, anemia, or if you have a clotting disorder, have you ever had your platelets measured? Any of those things are part of hematology, but hematology also looks at biopsies of bone marrow and of spleen. Now, in today's world, everybody knows about microbiology. We're living in a pandemic era, so you all know about infectious organisms. And microbiology is the field within pathology where all the laboratory work that's done for microbiology is actually being done. So although you'll hear people like Dr. Bogosh and some of the other big infectious disease specialists talking about our pandemic, they are very much relying on laboratories that do microbiology under the direction of a pathologist who is a medical microbiologist, but a microbiologist who works in the laboratory. And they're the ones who actually do all of the studies of infectious organisms. So when you hear about assays for even COVID, for example, the PCR tests that are being done in a microbiology lab that is under the umbrella of pathology. Now, the 4th component is what I'm going to focus on today, and that's what we call anatomical pathology, which is the study of cells and tissues and body parts, and even whole bodies. And I won't talk about that today because that's the autopsy, which is kind of what some people think of as being real pathology, but actually it's today a very small component of what a pathologist does. Most of the time, we are looking at either aspirations of cells or biopsies of tissues or resections of tumors to understand what the tumor is made of. What are the structural things that characterize it? What are the functional aspects of the tumor? So that we can actually determine what exactly is wrong with the patient and what are the specific prognostic factors that will predict how quickly the disease will spread, or will it be indolent? What are the specific markers that we can look at to say we can measure something in the bloodstream as a way of surveillance for patients who we think are cured? We look at tumors to decide what is the right treatment for the tumor. And that's really what I'm going to focus on in today's talk, because usually when we talk about a pathology report, we're talking about a report that an anatomic pathologist has generated to include all of this relevant information for your disease. Now, there are many different pathology specimens, and they're processed differently. So I'm just going to show you a couple of examples. Some people have what we call a cytology report. And cytology is really the examination of single cells that have been pulled out of a tissue. Sometimes, instead of just taking single cells, we can put in a needle that has a very large bore and we can take out a piece of tissue. Both of these generally are done through a needle. And I'm going to show you a picture, and I'm using as an example, and this is a picture from the public property of the NIH. This is a picture of a liver, and many patients who have neuroendocrine tumors will have liver biopsies to see if they have spread of their tumor into the liver. And this is essentially what happens, is that the clinician will put a needle into the spot in the liver, and sometimes it's just done clinically. More often it's actually done under radiologic guidance, so either under ultrasound or CT or MR guidance. We can put these needles into a lesion that we see on that imaging procedure. If it's a very fine bore needle, we aspirate single cells and we prepare them for examination on a slide as a cytology specimen. But if the lesion is large enough or the access is safe enough that we can use a large bore needle, we can actually stick the needle in and pull out a piece of tissue that is then processed properly to give us enough material that we can do multiple different specimens on it, multiple different examinations, and that's called a biopsy, which falls under the realm of surgical pathology. So here's just a clarification of that, if it's single cells or a piece of tissue. Then, of course, there's the opportunity to look at tumors and other pathologies when they are removed by a surgeon. Now, this is actually there's two reasons for this procedure. In the beginning, the reason that pathologists were asked to look at resection specimens was to actually document exactly what was removed by a surgeon. Sometimes surgeons thought they resected something and they didn't. Sometimes they took too much. Sometimes they did things they weren't supposed to do. So in some ways, pathologists were a little bit of the police, the medical police. But more importantly, today, we actually use these resection specimens to do all of the things I've talked about, including prognosis and prediction of appropriate management. And as I said, the last form of pathology specimen and reporting is the autopsy, which I hope we will not have to talk about for you. Now, I'm going to show you a short film that actually gives you an idea of exactly what happens during this processing. And you're going to see it, and I'll talk through it, and if you have questions after, I'm going to stop and answer them. But basically what you're seeing here is this is what we call the surgical pathology cutting room of a pathology department, where all the specimens come, and they are examined what we call grossly, meaning using the naked eye. And based on what we see in a tissue with the naked eye, we then take small samples of that specimen and we process them to be able to examine them in the microscopes. So let me just show you what happens. This is a pathologist or a pathologist assistant who's taking a piece of tissue. They're taking a piece that they're interested in, and they're putting it into a fixative, which then gets embedded in wax. And what you're seeing now is tissue that's gone through that fixation process. It's embedded in wax and it's hardened. And those hard wax blocks cut very easily into extremely thin sections that we float on water and then put onto glass slides. And then those glass slides go into very fancy machines where they're stained. And the stains can be what we call the standard stain, just to see what it looks like, which we call the hematoxylin and eosin stain, or they can be stains for special biomarkers. For example, as a neuroendocrine tumor patient, you may have heard of chromogranin. Most neuroendocrine tumors have chromogranin, and we can stain for that as a characteristic. So I'm going to stop now and just see, does anybody have a question, or does anybody want me to repeat that film just to see, so you would better understand how a biopsy or tissue handling works?
I'm not seeing any questions at this point, and I do not see anyone with their hand up, Sylvia.
Okay, great. Okay, so that was clear. Now what happens next is that the pathologist then examines those slides, and you can see in the background there was a microscope, but what I'm showing you is actually a much more modern way of doing pathology, which is on a computer screen, where you can actually look at the pieces of tissue, move them around, measure things to a very precise level, and really be able to get a wonderful grasp of what tissue pathology looks like on a digitized version of a glass slide. So if I just go back, again, you can see in the background the old-fashioned microscope, but here is the new computer. This is Dr. Andy Evans, who was a former colleague of mine at UHN. Andy is now the head of pathology at Mackenzie Hospital north of Toronto. And so anybody who's getting their pathology done there is in very good hands, because Andy is a fabulous pathologist. So now, unlike biochemistry and hematology and microbiology, where many of the tests are actually fully automated, they're done on a machine, the machine spits out a number or a positive or negative result. So for example, when you're measuring your blood sugar, you'll get a number and it will tell you, is your blood sugar too high or too low or in the normal range. If it's a PCR test for a microorganism, the result will come back positive or negative. But when we're looking at cells and tissues, it's not that easy. And this is why pathologists spend a lot of their time analyzing what's on those slides that we generate by staining the tissues that we receive and being able to interpret them and give our colleagues in clinical medicine, the surgeons, the oncologists, the endocrinologists, the gastroenterologists, we have to give them our opinion of what we have seen in the microscope or on the digital slide. We have to report what tests we've ordered. All pathology starts off with a standard stain. There are some that are different for cytology. In surgical pathology, all of the tissue slides are routinely stained with hematoxylin and eosin. And we look at those, and based on pattern recognition, we see things that will tell us whether something is a tumor. Is it benign? Is it malignant? Is it invasive? Is it metastatic? We can see things that are inflammatory, and we can say, no, this is not a tumor. It's an inflammatory process. It's benign. These are all different things that we see, and they're highly, highly interpretive. And one of the things that I have been focused on throughout my career is the recognition that surgical pathology is a very broad field. It includes breast cancer and lung cancer and brain cancer. It includes, oropharyngeal carcinomas, prostate cancers, colon cancers. These are all different kinds of diseases, and recognizing patterns in every tissue is highly subjective. And so because this is not just a number and it's not a black and white or a yes and no answer, we really need pathologists to become focused on highly subspecialized areas of pathology so that their interpretation of the material is the very best that it can be, based on experience, based on familiarity with what they're seeing, based on knowing what the biomarkers are that they should be asking for in each different example of a disease, and also becoming part of a multidisciplinary care team where they know exactly what to say in their report and the way to say it so that the surgeons and the oncologists and the other treating physicians know exactly what those findings mean for any given patient. And that's really what I mean when I talk about personalized medicine. Now, I'm going to start a little bit now of general details about what is in a pathology report. And this is something that I have had patients ask me about in the past, which is why I thought this is important. A pathology report has multiple components. There's an area that we call the gross description. Now, it's not gross meaning that it's disgusting. It's gross meaning that it's what we see with the naked eye. In pathology, we talk about gross and microscopic. In other words, what you can see with the naked eye and what you need to see with a microscope or with a digitized scan, where you can really blow the specimen up to a really high magnification to see the subcellular details. So in the gross description, we always describe what was received and how it was handled, because the way we handle a tissue, the kind of fixation that we've done, the length of fixation, how specimens were cut, You can just imagine, for example, I'll use something that's maybe more general than a neuroendocrine tumor. If somebody has a breast removed for breast cancer, breast is mostly fat. There's a little bit of skin sometimes on one side, and there's sometimes a tumor in that breast. And what the pathologist's job involves is to first characterize the tumor, but also to take lots and lots of sections of the edge of the specimen to make sure that the surgeon got it all out, because you don't want to remove a tumor but leave some behind. And the edge is all basically fat. Okay, and we paint these with different color inks, and that's when I say how it was handled, I mean what color paint did we put at which margin, so that when the pathologist looks at this in the microscope, we can say there's tumor at a resection margin, and we know it was the upper right or lower left or whatever. So the gross description is really the key to knowing exactly what was received by the Department of Pathology and exactly what they did to it and how they handled it, so that when you look at the permanent record, which is the glass slides, you can understand exactly what you're looking at. Otherwise, you'd just be looking at a whole bunch of slides of fat and slides of tumor and never know what was where. So the gross description is a really critical component, and the important thing about it is that it is no longer available after the fact. And that's why every single pathology specimen must have a gross description, because without it, there's nothing to go back to. We take these wet samples that are human tissue, which you know will deteriorate. We can't keep them forever. We can't keep them the way we receive them. We examine them, we weigh them, we measure them, we fix them in formalin so that they don't deteriorate. We cut them up, and then we take representative pieces, and those representative pieces go through the process I just showed you into wax blocks, which we can keep virtually forever. But the wet tissue that was not embedded, and we don't embed the whole thing in large resection specimens, the rest of that tissue all ends up going to the incinerator, usually within about 90 days of the report being signed out. So a gross description has to be there in every single specimen. Now, a microscopic description is where we put what we see in the slides. And I've had a number of patients ask me, you know, my report doesn't have a microscopic description. Why not? Didn't they look at the slides? The answer to that is that most of us do not complete a microscopic description in today's world. We used to in the old days, but in today's world, we are all required by law to retain the glass slides for a certain period of time. In much of Canada, it's 20 years from sign out, unless a patient is younger than the age of 18, in which case we have to keep them up till the age of 18 and then 20 years longer. In parts of the US, it's 10 years. There are differences all around the world. In some parts of the world, I have to tell you, patients take their slides once the report is generated, and they keep them themselves forever, as long as they want. But those slides are always available for somebody to go back to. And so the idea of filling in the microscopic description is done by some pathologists if they feel they have to justify their diagnosis. But much of the time we don't complete a microscopic description, because we know that once we've generated a diagnosis, if anybody ever challenges it or wants to understand why, the slides are available to go back and show them, and a picture is worth 1,000 words. Now, we also document in the report that ancillary tests were performed. So we say what those tests were and what the results were. That should be in every report where ancillary tests were done. And then, of course, there's the diagnosis. The diagnosis is what the pathologist's opinion of that case is. Sometimes there'll be a section called comment, and the comment is about other interesting or unusual features. And for example, I will tell you, in some patients, we can actually see from the pattern of a tumor that this might be a familial disease. And that's actually very common in neuroendocrine tumors. And that's something that a good pathologist will put in the comment. They'll say, we saw this and this and this, and we think this patient may have a genetic predisposition. We recommend genetic counseling or something along that line. Now, sometimes there are tests that need to be done that take a little bit longer. And we try and get our pathology reports done as quickly as we can. If they're small biopsies, we usually try and get them done within 48 hours at the most. If they're large resections and we have to do a lot of immunohistochemistry and so on, these reports can take a week. I know in some places in Canada they take even longer than that, which is a reflection of lack of staffing. But we try to generate a full pathology report in a timely fashion. But sometimes there will be a test that either takes way too long or that somebody asks about after the case has been signed out. Sometimes the clinicians will come back and say, oh, we didn't tell you, but this patient had such and such, either a symptom which we think may reflect an unusual hormone, can you do a stain? Or this patient's family has a history, can you look for something else that would be evidence of a familial syndrome? And when that happens, or for example, genetic testing, when we do molecular genetics for mutations on tumors, that takes a while, it's usually 2 or 3 weeks. We send that out, and then when the results of those additional tests come back, we do what we call an addendum, which is we add something to the original report. Now, once in a while, something was wrong. And when something is wrong, we have to not addend, that's add on. Sometimes we have to actually change or amend a report. And so if you have an amended report, it's because something had to change. Sometimes it's because the pathologist made a mistake, and we all do that. I make typos all the time. In today's world, I don't have a secretary anymore. I type my own reports, and sometimes I spell things wrong. So we amend the report for a typographical error. Sometimes a surgeon, this happened to me today, the surgeon told me something was from the left and it was actually from the right. He made the mistake. He emailed me and said, I'm sorry I made a mistake, but we have to fix this report. And so I had to amend the report to say right instead of left, or whatever he told me was the correction. So these are all different reasons to have an amended report, as well as having what we call an addended report. So I'm going to stop there because, again, I know people sometimes have questions, and Jackie, if there are any, I'm happy to answer them on this part of the talk at this point.
Sure, there is a couple questions. So I will start with the first one, which goes back a little bit in your presentation. The question is, what can be possible differences between a core needle biopsy and pathology performed following surgery? I guess for this individual, these were done at different hospitals. Which of these is likely to be more accurate? And how concerned should this person be with any differences, for example, the Ki-67?
That's a really good question. So that's actually a very common thing. We often will get a surgical resection of what we consider to be the primary tumor, and with it come things like lymph nodes or other metastatic disease that's known about and accessible at the time of the surgery. But then patients will sometimes have, for example, a liver metastasis that either isn't accessible at the time of the original surgery. I'll use as an example somebody who has a lung neuroendocrine tumor and has thoracic surgery for it, but that surgeon is not going to open the abdomen at the same time that the chest is open. Usually when it's in the abdomen, if there is something in the liver, they can get to it, but sometimes it's picked up later in the liver. And so when we see additional spots that we need, we will do a core biopsy. And it is not at all uncommon to find differences in some of the features. Sometimes the differences are significant and they suggest that maybe that metastasis is from a different tumor. And I have seen this, and I think there may be patients even in the audience who have had, for example, if you have multiple endocrine neoplasia, I've seen a patient who had a lung neuroendocrine tumor, and then they had a biopsy of their liver, and it turned out to be metastatic pancreatic neuroendocrine tumor because they had a different primary. That's a significant difference that changes management. However, if it's a lung neuroendocrine tumor in the first go around, and then the second biopsy is a lung neuroendocrine tumor in the liver, but the Ki-67 is different, that means nothing in terms of the tumor difference. It's the same tumor, but one of the things that we know about neuroendocrine tumors is that they are extremely heterogeneous. And that's true both between a primary and a metastasis, but it's also true within a primary tumor, and it's also true in different metastases. So you might have a lymph node that has a Ki-67 of 6 when the primary had a Ki-67 of 2, and a liver could have a Ki-67 of 1, all from the same primary tumor. This is intra and inter-tumor heterogeneity from the same primary neuroendocrine tumor.
Okay, so what if it was a scenario where somebody had, for example, a liver tumor that was biopsied using the core biopsy, and then they had a surgery on the same liver, obviously they only have one, but you know, then they had surgery to remove the actual tumors. Can there be differences between those pathology reports on that same tumor,
So
basically?
That's a great question. And the answer is that if there's a single lesion in the liver and the same lesion is biopsied by a core biopsy and then removed, one would expect them to be the same. However, again, remember that tumors don't always read textbooks, and they sometimes misbehave and they sometimes do change. So we could have, for example, in a 5-centimeter metastatic lesion, we may have biopsied a focus where the Ki-67 could be 3%, but in the 5-centimeter lesion, there will be other parts, and a 5-centimeter lesion would have at least 5 to 10 blocks of tissue for the pathologist to examine when it's removed surgically. We will find other parts of the tumor where the Ki-67 could be different. And that is not at all uncommon. The other thing that sometimes happens, which we don't like to see, is that we may have parts of the tumor that are very well differentiated. They may have lots of chromogranin. They look like they're pretty quiescent. They may make a hormone, for example, serotonin. They're behaving themselves. And then we might find other parts of that same tumor where we start to see a more solid growth. We start to see tumor cell death. We start to see things that we get really worried about because it means the tumor is misbehaving. And sometimes the tumors will start making what we call ectopic hormones. And that's a sign that the tumor is not behaving itself. It's misbehaving and it's doing something we don't like. But at least knowing that from the pathology, we understand more how to manage that patient.
Okay, thank you. So I've got one more, a little bit broader general question, and then we'll get you to move on. So this question is, should a NET patient's pathology report be seen by a pathologist who specializes in neuroendocrine cancer?
In an ideal world, that's exactly what should happen, yes. So again, I think this is an area where I have a very firm belief that it should be the case. Some of you will know that there are institutions where there is subspecialty pathology, and the subspecialists are the ones who do read those biopsies and report them. As Jackie said, I've been doing this for many, many years, and I know a lot about neuroendocrine tumors, and if I read a report, I'm very comfortable that I'm picking up things that can be very subtle that other people often miss. So yes, the answer is yes. Now, realistically, is that possible? Well, in Canada right now, there's really only a handful at best of people who I would say are even vaguely expert in neuroendocrine pathology. So the chances of you having an expert read your pathology report from the beginning are probably very slim. However, I would encourage you to, if you have concerns, ask to speak to your pathologist, or if your pathologist won't speak to you, which some of them don't, ask your clinician about the pathologist and their competence with this disease and whether or not it's worth getting another opinion. And especially if you have an unusual scenario, it's definitely worth getting another opinion. And the CNETS is always very, very happy to help patients who have questions like this. If they can direct questions to me, I'm happy to review reports and say whether they look good or not. And if there are inconsistencies or concerns, I can also recommend people who could be second opinion readers.
Great, thank you very much. We'll let you move on at this point.
Okay, great. So let's go to, what does a pathology report look like? So your standard pathology report usually has lots of space dedicated to some advertising. And then there's always something really important, which is the patient demographics. and that is the identification. And one of the things that we do really well in pathology is when we get a specimen, we very carefully examine the label on that specimen and the order, and we make sure that everything we need to know is there so that the right person is going to get their right report. That's something that's very, very critical. Then there's usually a list of specimens, and there can be one or many. I'll show you an example on the right. We usually like to get some clinical history from the clinician who's doing the biopsy. And then depending on the institution, the order of all these will be very different. I personally like to see the diagnosis very high up on a pathology report, followed by the comment, because those are the important things. Then any synoptic data, which is, synoptic data is a computer program where you can actually capture relevant information in discrete format, and it's a way of making pathologists remember that they have to report every part of, every component of what's important for a tumor. And then I leave the gross and microscopic description to the very bottom. Some hospitals actually have that right at the top after the clinical information. But as I said, to me, these are the least important things. The really important stuff is, what's your diagnosis, and is there a comment, and does that comment give you anything valuable? So this is just an example. It's from a publication, and this is completely anonymized, of course. But this is what the reports from University Health Network looked like when I was in charge there. We had set up our computer system to have the logo is a fairly small spot up at the top. You must, by law, have the department's address and phone number and fax and all of that information on a report, so that if there's ever a question, people know who to go to about that report. So the surgical pathology reports, I'm just showing you here one that's addended, so you'll know what that means and what it can look like. These are all the patient demographics, the name and the medical record number. Sometimes OHIP numbers are included here. The physicians who got the order, who made the orders and are actually expecting to get back the results. In most systems today, these are associated with either autofax or electronic notifications, so that the moment a report is issued and signed out, those physicians get a notice that your patient's report is ready and waiting for you. And then, of course, there's the patient's date of birth. There's the information about when the specimen was received and when the report was issued. All of these are important things. Somewhere here you'll see accession number. That's actually your surgical pathology number. And here are all the specimens. This is actually from a patient who has a lung tumor, and you'll see that they actually biopsied a bunch of lymph nodes, and then they took out the lung lobe. All of these are identifiers that the surgeons give us as pathologists, so we know exactly what we're looking at. And then at the bottom down here, you're going to see diagnosis. I use this because I had it as I didn't want to use somebody's real information, and it's hard to blank all that out. Not every hospital has this. This is a consolidated theranostic report, is something that we created at UHN, and which I actually am creating here as well in Cleveland, to add information about genetics when it comes back on tumors, so that you have the most up-to-date information when you get back something delayed. As I said before, we often will do addenda, which is we add something, and the traditional addendum falls to the bottom of the report. And when it's just something confirmatory, that's fine. But if it's something important, I think it's important that it should go to the very top of the report, and that's what this is really just a picture of. So that's pretty much your introduction to pathology and a pathology report. I thought I would just now quickly go through some of the specifics about neuroendocrine neoplasm specifically, to talk about what you should be looking for in your pathology report if you have a neuroendocrine neoplasm. So as I said, one of the key things is always to know what tissue. Is this a liver biopsy? Is it a biopsy of a primary tumor? Is it a resection of a pancreas? And if it is it the tail of the pancreas, or is it the head? Is this a lymph node with metastasis in it? There are so many different tissues that we need to know about, and knowing the site will help the pathologist also to sometimes distinguish between a primary or a metastatic tumor. Because sometimes, we see primaries in places where we don't expect them, and people think they're metastases, and vice versa. Once we know what tissue we're dealing with, we need to know what kind of tumor we're looking at. And in the case of a NET, specifically, we want to know where is it coming from. Let's say we're doing a liver biopsy and we have a neuroendocrine tumor. Many pathologists think that it's just good enough to say, well, this is a neuroendocrine tumor grade 1. You know, most of us really want to know a little more than that, especially if it's our tumor. We want to know where it's coming from. Is it from lung or from pancreas? Sometimes they start in ovary, sometimes they start in parathyroids. There are so many different tissues of origin, and we have available to us today biomarkers that can lead us to the right place. Once we know where it's coming from, we want to know what cell type is it. So, for example, the pancreas has 4 different neuroendocrine cells in the islets, and some of them make insulin and give rise to insulinomas, whereas others make glucagon, and some are what we call ectopic. They make gastrin, and they're called gastrinomas. So we want to know what cell type and what hormone is being produced, because first of all, it tells us about the differentiation of the tumor. Is this one that's behaving itself? If it's a pancreatic tumor and it's making insulin, it's likely to have a very indolent course. And we explain why the patient had symptoms before surgery with hypoglycemia. If it's a tumor making gastrin in the pancreas, that's not such good news, because normally gastrin is not produced in the mature pancreas. And so having a gastrinoma in the pancreas is not a good thing. However, this comes back to tissue. Sometimes there are gastrinomas that look like they're in the pancreas, but they're actually coming from the duodenum where gastrin belongs. So you're starting to understand that this is really complicated, and it's the job of a good pathologist to basically put the puzzle together. Take this specimen, figure out exactly what's where's it coming from, what's it doing. We have to do tumor grade. All neuroendocrine tumors must now be graded, grade 1, 2, and 3. If it's a neuroendocrine carcinoma, as opposed to a neuroendocrine tumor, it's by definition a high-grade tumor and doesn't need grading. We want to establish tumor stage, and staging is usually based on how big a tumor is. Is it fully resected? If it's fully resected, how far is it from the margins and what tissues did it involve before it was removed? And then we look at lymph nodes and liver and other sites of distant metastasis to say whether it's a stage 1 or stage 4 tumor, because clearly a stage 1 tumor is going to do far better than a stage 4 tumor. Then, of course, there are the more subtle things which not all pathologists look for, but the experts know to look for things like precursor lesions and to do studies of biomarkers for genetic predisposition and other predictive biomarkers, which I will show you as I go through my slides. So let's just talk about primary versus metastasis. Just quickly to review for you, neuroendocrine neoplasms start from the head to the pituitary. They're found in the thyroid. Medullary thyroid carcinoma is a neuroendocrine neoplasm of the thyroid. The parathyroid is a neuroendocrine tissue. The thymus has neuroendocrine cells. The lung, the pancreas, the gut, all the way from your mouth to the rectum. You have lots and lots of neuroendocrine cells, and that's why we see so many neuroendocrine tumors in the gut. And of course, as I mentioned earlier, the ovaries and even occasionally the testes can have neuroendocrine tumors that start in them. And then there's this whole family of non-epithelial neuroendocrine tumors called paragangliomas that go basically up and down the body alongside the aorta. You can see this red stuff here in the background is the aorta, the main blood vessel from the heart. All the way from the base of the skull to the tail, there are all these little paraganglia that are little tiny kind of neuronal-like structures that can turn into paragangliomas, and those are neuroendocrine neoplasms as well. When we talk about tumor type and tissue of origin, I just want to remind you that we have this classification now. I think I'm going to skip this slide in the interest of time. I've already said where these things occur, but as I mentioned a couple of minutes ago, we now have a new classification that is very clear that neuroendocrine neoplasm is a term for all tumor classes. We have well-differentiated neuroendocrine tumors, NETs, and then there are these much more aggressive, poorly differentiated neuroendocrine neoplasms that we call neuroendocrine carcinomas. And these are very different from neuroendocrine tumors because they have different biology. They're not as frequently familial. They're far more aggressive. They have different mutations and different treatments. And then the third family is the paraganglioma family, which is a non-epithelial neuroendocrine tumor type. Now, well-differentiated tumors, as I mentioned, need to be graded as grade 1, 2, and 3. And this is based on their proliferation rate, how fast the cells are dividing so that the tumor can grow. I'm going to skip that, and I'm just going to talk now a little bit about the role of immunohistochemistry. Now, I've mentioned this word several times, but I'm not sure how much it meant to you, so I put in a picture just to show you that basically this is a tool where you can see here that there are some cells. These are cells of a duct in a pancreas, and these are cells of a neuroendocrine tumor. And the neuroendocrine tumor cells are staining this pretty brown color. And the reason for that is that this is a stain for either chromogranin or a hormone that is in those tumor cells. It's not in the ductal cells, and it's not in the cells of what we call the stroma, which is basically just the tissue that holds everything together. So we can actually see within any given cell, we can see proteins that are inside that cell that allow us to determine what kind of cell it is and what it's doing. So we use immunohistochemistry a lot in neuroendocrine tumors. There are actually two fields in oncology where immunohistochemistry is so critical that you almost cannot make a diagnosis without it. One of those is in hematopathology, so lymphomas and leukemias. You can't make a proper diagnosis without lots and lots of biomarkers. The other is in neuroendocrine tumors. So we use biomarkers to confirm neuroendocrine differentiation. And there are lots of them. There are things you may have seen in pathology reports like INSM1, synaptophysin, chromogranin. There are so many of them, I'm going to forget them. But the important thing is that these are all proteins that are characteristic of neuroendocrine cells. So we can say that these are neuroendocrine lesions. We can confirm that they're epithelial or paraganglionic because the epithelial ones usually have keratins in them, whereas the paraganglia don't. We can tell their cell of origin by looking at some of the nuclear transcription factors, which are basically the directors of the cell orchestra that tell them what to do. Those tell you where a tumor is from. And then we can stain for hormones and say, this tumor is making insulin or a glucagon or a pancreatic polypeptide or serotonin. And that explains why the patient may have had hypoglycemia or hyperglycemia or diarrhea. These are all things that we can use to then say, oh, now we can measure this in the blood and be able to tell if the tumor is gone or if it's recurred, and if it's recurring, is it growing quickly? So these are biomarkers for surveillance. We use the same technology to look at the proliferative rate because when a cell is multiplying, it has a protein that we can stain with Ki67. So there's our grade. And then of course, stage. I'll show you in a minute that prediction of therapy, we can stain these tumor cells to see if they express somatostatin receptors. And many of you know that we use somatostatin as a drug to treat neuroendocrine tumors, and we use somatostatin radiolabeled as a target for radiotherapy to try and kill these tumors. And by looking for expression of somatostatin receptors on tumor cells, using immunohistochemistry, we can predict that a patient may or may not respond to the drug or the radiation. And then, of course, we have these new tools now where we're starting to use what we call molecular immunohistochemistry. We have stains for specific hormones or specific genes, sometimes even for specific mutated genes, to know exactly what is wrong with a patient. So here are just some pretty pictures, and the point of this really is just for you to understand what a pathologist is doing when we look in the microscope. Here's a parathyroid tumor and normal parathyroid gland. It's pretty obvious most pathologists can see the difference between those two. Here's an example of a medullary thyroid cancer, which is a neuroendocrine tumor of the thyroid. This is a benign parathyroid tumor, but this is a malignant one. And the way I can tell that is by looking for things like This tumor is infiltrating into its surrounding tissue, as is this one. And I actually could probably even predict that there's going to be invasion into a blood vessel here that will allow this tumor to spread out of the parathyroid to go to the liver or the lungs and bones and metastasize. And then here we have a very aggressive neuroendocrine carcinoma, which doesn't look nearly as nice and quiet as these, because these cells are really ugly. They're dark blue and smudged and really nasty. Now, you guys may not appreciate that, but I'm just showing you that this is a very interpretive thing that a pathologist does by looking at a slide. Here are just some biomarkers of lung neuroendocrine tumors, showing you that we can say it's from lung. We can tell you what to measure in the bloodstream. Sometimes these tumors make calcitonin or serotonin. There are so many different things that we can actually look for. Here's a small bowel neuroendocrine tumor. This is the normal bowel. Here's the tumor. It's infiltrated right through the wall, all the way down through the full thickness of the wall of the bowel. And you can see that because it's highlighted so beautifully with an immunostain. And this is actually the liver of the same patient, showing that they already have metastatic disease. And here's just a little tiny rectal polyp that was removed from a young patient. And the point I wanted to just make here is that, first of all, one of the jobs of the pathologist is to look all the way along this margin and make sure that none of these tumor cells are down there, so that we can say the surgeon got it all out and the patient is probably cured. And then we look at things that are unusual patterns or immunostains, because we know that there are at least 3 different kinds of rectal polyps that can be neuroendocrine tumors, and some of them are very good prognosis, the L cell type, others are highly aggressive, and some are in between. So these are just biomarkers that we use to try and understand this. This is just to remind me to mention, paragangliomas are completely different. They don't have the same structure or function, but we do the same thing by looking for biomarkers. There's a nuclear transcription factor, and in the case of paragangliomas, we can't actually stain for their hormones, but we can stain for the enzymes that are involved in the synthesis of these hormones to know exactly what they're doing. And some of you will know that, you know, you have to measure hormone products in either blood or urine for surveillance of a patient. And it's interesting because serotonin and adrenaline give you a very similar clinical picture. But if you have a paraganglioma, it's really important that you're not measuring serotonin, because you're never going to get the right answer. So I hope I've convinced you that we have all these wonderful biomarkers. This is just a very complicated chart, but pathologists, like everybody else, go through this process of saying, is it a neuroendocrine tumor? If it's not, we're going to do something else. If it is it a paraganglioma or an epithelial one? Where is it coming from? What hormones is it making? What's the Ki-67 labeling index so we can grade it? And then we stage these tumors. We go through this very prescribed process with every tumor. So tumor grade, as I've mentioned, Ki-67 and mitoses count. Mitoses are really hard to see. That's the least reliable way of doing this. Ki-67 is a little bit easier. You have to count how many positive cells are in a population of at least 500 cells. And this allows us to grade tumors as grade 1, grade 2, or grade 3. And that predicts survival. So if you have a grade 1 tumor, you're going to do well. Grade 2, a little less well. Grade 3, maybe a little bit less well than that. And if you have a neuroendocrine carcinoma, it's much, much worse. I'm not going to talk about tumor stage, because tumor stage depends on the organ. Staging in lung is different from staging in pancreas, which is different from staging in head and neck ones. Depending where the tumor is, the stage will be different. I just want to finish with talking a little bit about some familial syndromes. We now know that about 40% of paragangliomas and at least 20% of neuroendocrine tumors are familial, and I think those numbers are going to be out of date by the time I finish this talk tonight. Every day we are finding a new syndrome that is a familial mutation in a gene that predisposes somebody to developing a neuroendocrine tumor. And so more and more we are actually looking at tumors and saying we have to be able to stain for these proteins to be able to predict that a patient has a disease. So for example, here's a patient who has multiple endocrine neoplasia type 1, and I could predict that by looking at the pancreas that came out. They knew that this tumor was there. They didn't know about the small one. Most people would have said, oh, it's spread from that one, but because I stained for hormones, I could tell you that these were two completely different tumors. One was an insulinoma, one was a glucagonoma. The surrounding pancreas had tiny little lesions like this instead of normal islets everywhere, and I could tell that this was going to be a genetic predisposition syndrome. I could see things even in the normal islets of this patient that said that this was not normal. I won't go into the details, but the important is if you have an antibody to the protein for MEN1 and you see that these tumors are negative in all of the little foci where you see them, you know that this patient has MEN1, and that means that we can help the patient to prevent the development of other tumors that you can get in MEN1, and we can screen them and their family so that we prevent things from reaching a stage where they're not treatable anymore. I'm going to just skip over these because I don't think they're so important. I just want to end with one last slide so that we have time for some questions, and that is just to remind you again the other predictive and prognostic biomarkers. Now, I'm showing you here a picture of somatostatin receptor type 2. This is an immunostain which is readily available and which we now can use on any neuroendocrine tumor. And the important thing is that, you know, you can do a gallium scan and you can see that there's uptake in the tumor, and yet a patient doesn't respond very well to that drug. And I think we've all kind of come to learn that with each new advance, we think we have this great tool, we are expecting it to be the magic bullet, and invariably science and biology teaches us a lesson. And one of the lessons that we're learning is that although a tumor can take up somatostatin and it might be effective, in some cases, patients have tumor cells like these, where you can see that, you know, although most of this tumor is really positive for somatostatin receptor, there are some bad actors hiding in the background here that are negative. And so looking at this, I can say, oh, this patient is one who either needs a very high dose or multiple therapies, or maybe is simply not even going to respond to SSTR, to peptide receptor radiotherapy. And we know why. And we now know that we have to start looking for other biomarkers to treat this patient with a different and alternative mechanism, because this may not work. And there are many new predictive biomarkers coming out because there are new drugs. And you know that every day we come up with new drugs that target different signaling pathways in these tumors. And we hope that we will be able to eventually use tools like this one to select patients and say, this patient is not going to do well with drug A, we're going to take drug B because they have the target for that. So on that note, I'm going to stop, and I hope that you have some more questions. We still have a few more minutes. I think we have about 5 minutes left for some questions, and I'm more than happy to answer questions about any part of the talk that I've done so far.
Thank you so much, Dr. Asa. It's an incredible presentation. We do have more questions, definitely. So I will try to get to them all. So this person wants to know, what is the TTF1 marker? And is there a reference chart somewhere that outlines all of these codes?
So TTF1 is a transcription factor. I used that word a few minutes ago. Transcription factors, it's thyroid transcription factor 1, TTF1, and it's basically a protein that drives the development of the thyroid and the lung. It was called thyroid because it was first identified in thyroid, but both the thyroid and the lung derive from the same place embryologically. And so TTF1 is one of the markers that we use to decide if a tumor is coming from the lung or thyroid, or is it from somewhere else. And that's especially relevant when you have a patient who presents, for example, with a metastatic liver lesion, and we don't know where the primary tumor is. Now, that being said, I don't know all the details behind the question, but as tumors become bad, and particularly in the field of neuroendocrine carcinomas, which are the very aggressive ones, they all start to misbehave. And so TTF1 is actually a fairly promiscuous transcription factor that when a tumor goes bad, it might start making TTF1 even if it's not from thyroid or lung. But if you're dealing with a neuroendocrine tumor, a NET, usually TTF1 positivity should point you to either the neck or the lung as the primary site.
Okay, great. So we have a note here for you from Dr. Met, who is with us today.
Oh.
Dear Sylvia, will you consider discussing a bit the good news that pituitary adenoma is now replaced by pituitary neuroendocrine tumor terminology, PIT-NET, which will facilitate a better patient care for affected patients?
So that's a great point, and I think he's made the point now. I don't really have to prolong that, but yes, neuroendocrine tumors, for many years people thought of them as being from the GI tract and pancreas. We then realized that lungs, what we were calling carcinoids, they're all part of the same family. In the last 3 to 4 years, there's been a huge increase in understanding of neuroendocrine tumors, and in the new WHO classification that will be coming out within the next few weeks that both Dr. Mete and I have been working on, we now are making the transition to have all neuroendocrine tumors classified under the same umbrella. And yes, pituitary is definitely in this category. They are probably the most characteristic neuroendocrine tumors in terms of having been characterized by pathologists like Dr. Mete and I into very clear understandings of cell type and hormone production and tumor grade based on function and structure of a cell. And so he's excited, as am I. I know many of people in the audience will not be because you don't think of them in this context, but I think they're a great model for the rest of us to want to follow.
Great. Next question, when was the identification of tumor grade mandated?
That's a good question. First of all, I'll start by saying nothing is mandated, but guidelines do come up and they kind of direct people in what's best practice. Grading has been probably, I would say, almost 15 years now we've been grading neuroendocrine tumors, but in different ways, and that's part of the challenge. And so I'm going to say something now which might be a little bit controversial, but many people agree with me, not everybody. We grade tumors everywhere outside the pituitary as Ki67 with a number that's Ki67, and we have cutoffs. And some of you may know that the cutoffs have changed over time. So it used to be that grade 1 was 2 and under, and now it's 3 and under. And then there's 3 to 20 and above 20. And I asked people when they made the change about 5 years ago from 2 to 3, I said, why? And they said, well, there are lots of tumors that are in the 2.7 category. And I thought, well, that's really kind of stupid. The fact of the matter is that, first of all, the quantification is extremely variable depending on technique, the stain you use, the way you count, all of these things make a difference. The other thing that's very important is that Ki67 is a continuous variable, and no matter where you draw a line, you will find differences when you lump patients under 5 to 20 and 20 and above, or if you go under 10 and then 10 to 30 and above. No matter how you draw these lines, you're going to see differences. But I like to remind people that what really matters is the number and the variability within a given tumor. So obviously the highest number is the worst, but we're going to do better with time, I think. But for now, we use what we have as a standard grade.
Okay. Next question. If I have two tumors, rectal and ileum, that the report says are not histologically related, does that mean I have two primaries?
Yes, that's exactly what it means. So a patient can have two different primary tumors. It's not uncommon in neuroendocrine tumors because the factors that predispose you to get one may predispose you to get another. And of course, as I said, and this is important for whoever asked the question, whenever a patient has more than one primary tumor, we must think about the fact that there may be a genetic predisposition and you may have some underlying risk of developing parathyroid tumors, pituitary tumors, pancreatic tumors, and so on, you and or your family. So multiple neuroendocrine tumors is not uncommon and it has implications.
very important information. Thank you. Next question is, can you please clarify what is SSTR2?
So SSTR2, so somatostatin, which some of you take as a drug in various forms with different commercial names. Somatostatin is a hormone that's produced in the pancreas that is, for some reason, one of the only hormones that seems to stop all other hormone cells from doing what they do, including making hormones and growing. And we abbreviate somatostatin as SST. And it works by binding to receptors that are on the membranes of other endocrine cells. And we call those somatostatin receptors, so SSTR. And there are actually 5 different members of the family of somatostatin receptors. So SSTR1, 2, 3, 4, and 5. And SSTR2 is the one that is most useful in predicting response to therapy, both using somatostatin analogs, short and long acting, as well as peptide receptor radiotherapy.
Okay, thank you. So I don't have any more questions from the audience, but just before we wrap up, I do have one question for you that we hear a lot from patients at CNETs, and that is there at any point in a patient's journey in which they should be asking for their pathology to be repeated?
Yes, so that, I mean, obviously it depends on the patient, the tumor, and the pathologist. But yes, so I'll make a few comments. First of all, if I've always told patients that the pathologist is somebody you don't usually see. Very few pathologists actually meet with patients. Jackie will tell you that I do, and I love it, but many are not comfortable because they're not really used to doing this, and they give reports to other clinicians to act on. But the pathologist's decision is one of the few things that really will change your life and your treatment. And so it's a very important part of what you get. You know, you can be seen by a doctor who'll give you a drug, and if it doesn't work, you'll get a different drug. You can be, you know, there are some things that don't matter quite so much. Surgeons matter a lot. Once somebody cuts something, it's gone, and where they cut matters, and you can't change it. Pathology is really, really important, but it can be reviewed. And so, you know, I like to encourage people to look at your pathology reports. Ask your physicians for a copy if you don't have one. Go online and get it if you have access to your chart. Read it, ask questions. That's what we're here for. Some pathologists like Dr. Mete and I are happy to, you know, answer questions from patients. We're happy to teach. We're happy to help you understand what's best for you, even to give you individual counseling. But if you're not comfortable with it, you can ask for another opinion. There's absolutely no harm in saying, I want another opinion. If your doctor says absolutely not, there has to be a reason. One is that it's very clear. If the pathology fits perfectly well with everything that's going on clinically and your response to therapy and your clinical manifestations, then you probably don't need it. But if there's anything that you're worried about or unusual, or things just don't seem to be going right, there's no harm in having a pathology review. The other side of that question is that sometimes tumors change over time. And so a report from for example, a small bowel tumor that was resected 10 years ago and has been very indolent, and now there are liver metastases and they're growing very quickly, it's probably the same tumor, but that tumor has changed in the last 10 or 15 years. And so sometimes it is important to have a second biopsy or a third biopsy and actually look at the tissue and see what has changed, because that will change the treatment.
Excellent, thank you. So we do have one more follow-up question on the SSTR2. This person is asking, is the SSTR2 then used to decide if PRRT is an option?
So currently that is not usually the case, but occasionally it is now being done in some centers in the US especially. I think SSTR2 staining is not really being done in Canada right now, but I think that's going to change very soon, because as I've said, first of all, there are 5 different SSTRs, and you can't tell which is which by the gallium scan if there is uptake. But there are 5 specific different antibodies. And second of all, as I've shown in the picture that's up now, there are differences in intratumoral heterogeneity in terms of expression. So there probably is a role for expanding our use of this tool in patient management.
Great, thank you. Okay, well, we don't have any other questions and we've gone over time, so we really appreciate you taking the time to answer the questions and for providing such an excellent presentation. I'm sure that many people have benefited from this, so thank you as always for your time and for your support of the neuroendocrine community. We really appreciate it.
It's always a pleasure, and I'm happy, Jackie, if there are patients who have questions, you know that I'm always happy for you to share my email, which you have, and they can get in touch with me. Okay?
Absolutely. Thank you so much for always being there for us. We truly appreciate it.
Thanks. Have a
So
good
thank you everyone for joining us. I think that concludes our session for this evening. So we hope you have a good rest of the day. Thank you. Good night, Dr. Asa.
Night.